everybody can see this. Get the slides going. There we go. So I know that the majority of you are prescribers, although we have some behavioral health psychotherapy folks on the meeting today. I have nothing to disclose related to the content. I'm going to be just providing a brief overview of a model of intervention called harm reduction. This and relapse prevention, we tend to throw around and use them interchangeably, and that's not necessarily the case. And so I think the vast majority of you are going to recognize that you're doing some form of harm reduction with the patient population you're working with, and that this isn't necessarily a therapy, but it has therapeutic interventions under the model of harm reduction. So I want to tie all that together for you. I want to be able to discuss the conceptual model so you can say very clearly this is harm reduction, this isn't, and also contrast it to kind of the historical frame, which is our abstinence only model, address how it could be applied and benefit a clinical population, particularly individuals with substance use disorder. And then I'm going to wrap up at the end by showing you some example techniques that can be applied to most of the patients that we work with. So hopefully that will give you a good overview. I like to start talking about this topic by grounding it in a historical perspective, because it's important to be able to differentiate, especially that difference between a harm reduction model and an abstinence only model, because it has some implications for how a program would operate or how a provider would operate with a patient. And so recognizing that we have a long history of treating individuals with substance use and addiction, we have treated that patient population very differently across time. And we've brought some of the biases or perspectives from that history forward with us. And so in order to apply harm reduction effectively, I think it's important to challenge some of those biases that you may or may not have, but they may be in there, that have come from that history or come from the culture in which we're currently operating. So I'm not going to go exactly and give you the timeline necessarily in this lecture, but know that really from the beginning, individuals with substance use issues, we originally started dealing with a lot of those folks from a criminal perspective. So to remove them from society, to put them in treatment programs that were removed from their family or from their culture in order to achieve a level of sobriety or abstinence, and then they would be allowed to return. We've punished or criminalized a lot of the behaviors around substance use. So things like public intoxication, or having drugs on your person, getting involved in selling or using drugs. And we've had different movements across time, like the temperance movement, or even as recently as the 80s and 90s, when we had the War on Drugs campaign. Those were all viewpoints that emphasized treating addiction as a criminal behavior, that behavior needed to stop and removed from society. We also have a history of treating individuals with substance use from a perspective of having a moral problem or failing. So really viewing addiction as a lack or a failure of willpower or having a weak character. And there's even some misinformation out there about individuals having an addictive personality. And so that still carries with us in a lot of the treatment models that apply, particularly under the abstinence only umbrella, because it's viewing it as that should be the end all be all outcome for individuals, and anyone that hasn't achieved that is lacking in some way, or that we have to wait until people have the willpower, the motivation to actually make positive changes. And when we talk about the harm reduction model in a minute, you'll see how that can be, those two don't always go together, and how it can really be kind of harmful to have this mindset that patients with addictive behaviors are morally weak or failing in some way. Later, starting in the 1800s and carrying forward, we've gone through periods where we've treated addiction as a disease, and we've seen that from a disease process, and sort of saying that there is something that has caused this disease, and then there is a treatment or a correction for that. So that cause and effect relationship. And we know there's an aspect with a substance use disorder and addiction that the disease model does apply to. However, it doesn't account for everything. And so the most modern viewpoint that's endorsed by NIDA and SAMHSA and so our major research institutions is viewing addiction not so much as a disease, but as a condition or a disorder. So that means that it is multifaceted, that there are aspects of change that occur in someone's psychology, their physiology, and their social relational environment, and that those things are dynamic, right? So it's greater than the sum of its parts, that we can't just look at it from a purely biological perspective, that we can't look at it from a purely psychological perspective. We need to account for all of those facets to really effectively treat this condition, because it is much more complicated than a straightforward disease. The other important thing to keep in mind is that this is a chronic condition, and that it is similar to other chronic conditions like asthma or hypertension or diabetes. There's a heavy genetic contribution, which I think is important to counter some of that moral failing weakness history, that people don't necessarily choose to have that vulnerability. Just like people may not choose to be vulnerable to their diabetes, and certain lifestyle changes can turn it on or can have an influence in affecting its improvement. We want to think about substance use the same way, that there is that interaction between the environment and personal choice and the person's biology or their genetic vulnerability. We know that medication adherence and relapse rates look very similar with substance use. In fact, substance use looks a little bit better than medication adherence and relapse for conditions like asthma. And that long-term maintenance has been shown to be the most effective, that we don't want to treat these folks episodically. We don't want to put them in that remove them from their environment, residential rehab setting, and then when they come out, assume that they are completely treated. They're going to need a step up or a step down at some point in the continuum, and usually some level of maintenance care for a very long period of time in order to maintain the gains that they've made in some of those more acute or higher level treatment settings. So why is this important? Well, it's important for thinking about the treatment that you provide to this population as being continuous rather than episodic, that our goal is not to cure the condition, but to seek a functional improvement, right? So can this person function more effectively than they did before? Can they decrease their use and be healthier along that continuum, regardless of if they've achieved abstinence or not? And that's not the only outcome, that really our focus should be on functionality and health rather than sobriety. And harm reduction is really an awesome model for leading to substantial improvement from that functional mindset. So to reduce rather than focus on cessation, to allow patients to enter treatment and sustain in treatment even while actively using, to focus on things like social, personal, vocational improvement, and not just their use behaviors. And that results in not just improvement for the individual, but improvement for the community, both from a monetary standpoint and a safety standpoint. So this is a stepwise visual to sort of show you where the recommended interventions would fit. So for most patients early in treatment, new to treatment, or who are in an acute phase of their recovery process, so their symptoms are fairly acute, we really want to be thinking about a harm reduction set of approaches. So really helping them be as healthy and functional and safe as possible right now, regardless of their use, or thinking about how are they using, and can we intervene with some of those variables rather than holding that abstinence piece as the end all be all. As they achieve some level of safety and stability, then we can apply a lot of our CBT techniques, which are very effective at helping people with these conditions, and then wrap up once they move into sort of firmly in action, moving into the maintenance stage of change, focusing on those relapse prevention skills. So you can see harm reduction and relapse prevention really bookend a successful course of treatment. So what is harm reduction? Well, it really is a philosophical model. It's not a set of interventions or an intervention in itself. And it's adhering to these principles, having respect for the individual, collaborating with them, recognizing they are the expert in their course of care. And so they're not going to do anything that that we're telling them to do. We need to collaborate with them on what their treatment goals are. Having compassion and empathy for where they are when they show up, encouraging at all times acceptance and empowerment. So teaching them the skill set or encouraging them to learn the skill set that is needed for them to be healthy and functional. We do harm reduction all the time. We just may not be labeling it as that. And in fact, this came out of community or health psychology. It's the origin of where a lot of harm reduction comes from. And it was developed to help improve large groups of people and the safety in general, not just interventions for individuals. So things such as sunscreens, seat belts, use of bike helmets, medication-assisted treatments, all of the things that you guys are here to learn about in terms of ORT or naloxone, even prescribing things like nicotine supplements, clean needle exchanges, having safe injection sites, doing sex education, condom distribution, directing people to where that they can get free HIV Hep C testing or prophylactic medications. All of those things are examples of harm reduction and ways that we can help our patients be healthy and safer than dealing directly with the use. So our major goals within harm reduction is to, again, focus on reducing those harmful consequences that are associated with their high risk behavior. So looking at what they're doing that is posing potential risk for them and helping them to modify that set of behaviors to be safer. So the focus is really on what can you do right now, not what you need to do tomorrow. What are you going to do today to stay alive and move towards greater functionality, and collaborating with them, because it's going to be a unique set of change behaviors based on their level of readiness to change and the unique variables that are contributing to their particular case. With using harm reduction, again, contrary to a lot of abstinence-only models, we are not going to force a standard. So that means that if you're working with patients that are actively using, or even if they come in intoxicated, you don't turn them away from treatment. You try to do what you can for them then and meet them where they're at. You try to create attainable SMART goals to set them up for success rather than really large, unattainable goals that require a level of decreased use or abstinence in order to move forward. We know that when we apply confrontational or judgmental approaches to this population, it only exacerbates and increases that internal stigma, which increases their risk of overdose or death related to failure to engage or maintain in treatment. So if we can keep them in treatment, even while actively using, and work on decreasing some of those high risk behaviors, we are going to have more impact on a positive prognosis. Here are just some graphs that show you, I think in stark numbers, the effect of one harm reduction model, buprenorphine maintenance, versus detox. So a lot of people have seen this study. It's very stark when you look at the buprenorphine trial, which had 0 deaths and maintained patients in treatment, versus the placebo who did not have an opiate replacement, and how they had 4 deaths and a number of stark dropouts from treatment. So there's a big difference in our retention and an overall outcome. Also, looking from a community perspective, this was a study that is helpful with looking at methadone treatment and criminality. So you can see that before treatment, we had high numbers of patients engaging in criminal involvement to maintain their use. And then after treating them, so basically removing them from that withdrawal intoxication cycle by providing methadone maintenance, their criminal involvement dropped starkly. So a lot of that old mindset of substance use disorder has to be associated with criminality, or is in and of itself a criminal behavior that need to be removed from society. We can see that that's not the case. We take those same patients that have engaged in those behaviors and provide them a harm reduction intervention, and we see major changes. And this study I like to include, even though we're not providing anything like this in the United States, the study came from Switzerland. They wanted to look at what happens if we provide a prescribed heroin to people. So these are patients that failed out of a methadone or buprenorphine or other opiate replacement trial. And they were very, very high risk. So we had patients that were high risk for death due to overdose and death due to AIDS or HIV infection. And so in I think it was around 1991, or 1992, they decided for that group of patients, they would do a trial where they would just prescribe them heroin. So it was, they were able to come, inject in a safe injection location. That nothing changed in terms of their substance use, but you can see big decreases after they initiated that program in terms of death due to overdose or death due to secondary infection. So I think that in and of itself, if we change nothing related to the use behavior, but we make it safer to use, we can see improvements in outcome. So from a harm reduction standpoint, we assume that individuals who use substances are experts in their experience. They have strengths that they can apply to make positive change, that in fact they want to make positive change. We can, as healthcare professionals, align with those strengths and bolster that functionality. In terms of their substance use, we can acknowledge that it exists in really complicated ways, and that this is a relationship that they have both with the social, environmental pieces that are connected to their use, but also to the drug itself and the experience of that. What is it doing for them? And so it's not as simple as just removing it and they'll do better. That we can categorize all of the potential harmful consequences around their use along a spectrum. And that gives us a lot to work with, even if we can't do much with their use, or they're not at a place where they're willing to talk about their use itself. And so to start working with harm reduction, we want to start by collecting information. So the first step is to get information on the drug set and setting. And so this is a nice graphic that shows you all of the data that you'd want to collect about the substance itself. How frequently are they using it? Is it legal or not? What is the quality or the type? Information about the set, so that's the person, right? Their health state, their mental health state, their culture, their stage of change, why they use it, their reasons for use, all of those things. And then the setting, what's the environmental contextual variables? And there could be points for intervention in any of these three bubbles, but it's important to understand kind of how they're connected to start doing or applying a harm reduction model. So I want to go through just some basic techniques that fall under this umbrella in case these would be useful for some of you. So one of the techniques that, again, we're using harm reduction at the beginning of treatment, or patients that are in more of a pre-contemplation stage of change, is something called a decisional balance. This is a fancy pros and cons list. With a little bit of a twist on it. So you can see on one column, we have continuing the behavior. What are you getting out of continuing to use? What are the cons, or what are the consequences of continuing the use? And then on the far right, we have changing the behavior. What are the costs or consequences of changing or decreasing your use or stopping your use? And then what would be the potential pros or benefits? So here's just an example of what that might look like. An important thing that people often forget with doing this pros and cons list is to add numerical weights. So on a scale of 1 to 10, how much of a pro is this, or how much of a con is this? Because that helps you to calibrate these specific items more effectively. So you can see on here some examples of helps me deal with my pain. That's a 10 versus like makes me feel good, right? So even in the pros, there's going to be variability. Then you want to take that numerical scale that you've put on those items and create a hierarchy of need. So I might start with somebody and what they're telling me is, oh, I need to help them stop using methamphetamine or opiates, that in my mind, that should be priority number one. But once I do the decisional balance, I can see actually it's managing their pain that's number one. And so that totally shifts the interventions that I'm gonna be working with. So this is a really great exercise to do with somebody at the beginning of treatment to help define those treatment goals, because it sets up, again, collaborating with them, what's important to them for doing that hierarchy. Another piece that is falls under the harm reduction umbrella is logging and tracking. And so here's an example of a log that you could give to somebody and have them do a week or two to collect the information about those positive, negative consequences and what are the triggers, thoughts, and behaviors associated with it. So here's one that's filled out that you can see that you can use as an example to say, how would somebody fill this out and why would this be helpful for me as their provider to know this information? Here's another just general log that would just tracks the date, the situation, their cravings and how they cope with it. So you could track use, you could track cravings, you could track the triggers, a number of things, but logging and tracking is very much a part of starting a harm reduction process because you need that drug set and setting information. You need to collect that information to be able to tailor the recommendations and interventions. And then lastly, a really, really important technique that falls under harm reduction is looking at high-risk situations, or what's called high-risk situation planning. And so that's something you can do every single session. For my patients, the last 5 to 10 minutes of every encounter, we do a high-risk situation plan. So we go through, okay, between now and the next time I'm going to see you, what are the things that are going to come up in your life that you know are coming down the road that are either going to be triggering or going to put you in a position to use. And let's come up with a plan for how to deal with that differently. So it's sort of like setting up a mindset where they can think into the future and begin to practice what they're going to do instead. And so high-risk situation planning is a really, really important component of starting to decrease somebody's overall risk. Okay, so that's my overview, and I think I ended 1 minute